So I am Professor John Charles Okiria, the chairperson Allied Health Professionals Council Uganda, the council that is mandated to regulate, control, register Allied Health Professionals Councils. These professionals cut across, and they are 38 in number currently, and this is one of the biggest councils in Uganda. The board members for all different categories of people, the association leaders for all different cadres. One of the major requirements is the review of the Act, Allied Health Professionals Act, that was directed by Parliament, that the councils go ahead and review. Our Act was enacted in 1996, and since then, several things have happened in terms of population growth, disease burden, increase in number of cadres, increase in challenges of service provision, demand for quality, and all the aspects of demand for regulation, introduction of new equipment and new medicines, and all these are supposed to be captured in the new regulation. And so today was a very important day as we meet the key stakeholders to be able to provide input on the existing act to see how best can Ministry of Health through Council regulate the practice of the allied health professionals in this country. We have agreed on the sections of the Act that we need to have proposed for amendment. We have harmonized the positions on a number of issues, including the practice, the profession, the persons to be regulated, the registration processes, and also aspects that give security to our clients, the patient's care, and all these aspects have been included in today's discussion. So we believe that if all these are included in the new Act, we should have a better regulation and the public should get better protection and services from the professionals. One of the things that has been happening is that the ESC has some resolution that we subscribe to, and one of them is a harmonization of curricula and transfer of credit, that we are going to be looking at the details of how do we have a person trained in Uganda, trained in Kenya, trained in Tanzania, trained in Burundi, have his skills transferable without any doubt, knowing that what he was trained is similar across the board. So the harmonization of the curriculum is ongoing. So this is going to strengthen the training and the recognition and mutual transfer of professionals across the East African region. It's one way to make sure that we all identify and we all recognize that the institutions that are training, the people who qualify, are the same people who can be working across the board in the ESC. So once then we have harmonized the curriculum as the associations and boards, it is easier then to have a clause that allows the mutual recognition of qualifications. So if you trained in Kenya, you trained in Uganda, you simply come to here and we give you a license to practice. If you are trained in Uganda, so this is now free labor market movement. If you are trained in Uganda as a clinical officer, you'd want to go and practice in Kenya, you will still be given a certificate to practice in Kenya. So this is going to be one of the biggest achievements in the processes. And this process is ongoing, and we know that in a short while, we should be having free transfer and movement of labor. Of course, in the other side, is disadvantage that countries that have better pay may attract more of our professionals than the others, but nevertheless, everybody wants value for his labor.
Yeah.
So my call to professionals, first of all, is that we have had an opportunity to input in this law. This law is supposed to regulate our practice and profession. I call upon the professionals to understand that our services are derived needs. It's because people are get sick. We are dealing with the right of people. That's the right to live. Clients, patients is the reason we exist. Is the reason that we are being trained. So the way we handle them, the way we generally treat them is very critical in the service delivery. I call upon the professionals to remain professional and ensure that these people are professionally handled the benefit of humanity.
Peter, I'm the acting registrar of Allied Health Professionals Council. The Allied Health Professionals Act, Chapter 268, which I have here, was made in 19 96. So many years now have passed. And since that time in 1996, there were very few allied health professionals in the country. There were about 21 allied health professionals who are specified in this act. But as we stand now, we have 38 allied health professionals in this country. And most of them have progressed from certificate to diploma, and others from diploma to degrees and masters and so on. So the purpose of today's meeting was to propose the amendments which will be put in this act to suit the current situation. We invited presidents of associations. We have 20 allied health associations. We invited chairpersons of boards and secretaries. So we have been in a discussion to see how we can amend this act. And we discussed those amendments from section 1 up to section 56, where the act ends. And we hope after this work, we are going to propose, we are going to write these proposals of amendments and give them to the first Parliamentary Council to draft what they call legislative drafting, and then also add on principles to the bill. Then from there, it will be given to the Minister of Health, who will table it in Cabinet for Cabinet to approve the amendments of the bill. So yes, the major gaps were mainly three. The first one was the new professionals who were put on board after the commencement of the act were not in the act. Those are the environmental health officers, the nutritionists, and so on. So those cadres had to be now incorporated in the new act. Secondly, the professionals who were allowed to do private practice, that is having private clinics and so on, they were also very few in the act, because by that time, most of these professionals were stopping at a diploma. But now we have professionals who have advanced up to a level of a degree. If you can see, clinical officers have now a degree, physiotherapists have a degree, dental technologists have a degree. So those professionals were not allowed to do private practice according to this act. But now, as per the amendment, they will be allowed to do the private practice. Then another gap was on the years of experience. Because originally, somebody to be given authority to do private practice, it required an experience of 4 years. But now with the current technology and advancement of science, that experience can be reduced, and it has been reduced in this gathering. Now it will be experience of 3 years. So after having qualified with your diploma in clinical medicine or diploma in physiotherapy, and you work for 3 years, then you can be licensed to practice on your own. So those are the 3 gaps that we worked on in this act.
My name is Ali Patrick Dennis, the chairperson of Allied Health Professionals Associations in Uganda, but also the president of the Uganda Medical Lab Technology Association. I've also been elected as the vice chairperson of Allied Health of Professional Associations in Africa. The purpose of this convening was to review the Allied Health Professionals Act. This is the law that guides and governs the practice of professionals in Uganda. There have been a lot of gaps, and as cited by a number of stakeholders in a number of meetings right away from the ministry, our mother ministry, that needed to be reviewed. And this comes most especially after the aspect of the merger was deferred, and therefore encouraged that the acts be reviewed. And at this particular time, we looked at the act in totality from the beginning up to the end, and we are very happy and satisfied as presidents of all the Allied Health Professionals Associations in Uganda that the areas that were contentious have been captured. They have been reviewed. One of the areas of contention included private practice, which has been in a way kind of limiting, and so the regulation of private practice has been solely mandated under Allied Health Professions Council. And the other one was about supervision of these health facilities, that it will be solely embedded under Allied Health Professions Council, which us as professionals really appreciate government for this. And we want to send a message to the Ministry of Health, the Honorable Minister, They thank you for being very, very instrumental in ensuring that she gives the mandate to the professionals to, take lead in their own professions. We are very appreciative of the council, Allied Health Council, the chairperson, Allied Health, and the registrar for the good work they've done. All professional presidents have been here. The Allied Health Professionals Associations are up to the tune of 38, and all of us were here. We have been able to review a lot of articles, sections in relation to practice. We've noted that some pharmacies, for example, that have been masquerading in doing aspects of testing, and yet they are not supposed to test. The official from National Drug Authority clearly echoed out that if any of them is doing them, then that's very illegal. Our colleagues in the clinical medicine practice have been reassured their profession will be still stand as it is as medical clinical officers. Of course, many other proposals were made previously that would really want to affect our practice, and that all has been clarified here, and we are content of whatever we've done. Well, whatever has been captured from our inputs is going to be presented to the minister, and hopefully the final act will come.
By the name of Alex Kachuano, I am the Secretary General of the Allied Health Professionals Association Alliance. In today's discussion and amendment, we realize that our scope of practice will be followed, and it will be regulation in line with the scope of practice for the various cadres under Allied Health Professionals Council. We have looked at the boards that advise the council, the numbers that are supposed to be there, and how each profession is supposed to be represented therein. And so we have gone further to actually elaborate on the fact that in 1996, when this act that has been in existence was put in place, we only had the certificates and diplomas. But as we speak, we have professionals from certificates to PhD. And so following that and the changes in the need for various specialties to evolve, we have agreed that instead of just looking at allied professionals in terms of diploma, we include sections that actually elaborate on the career path to bachelor's and the specialist to be registered as specialists, not just additional qualifications. Yes, we see that the ministry and the various stakeholders ahead that are likely to see this are positive, and we expect that all our suggestions will be highly considered for a positive and a better standard within the health sector of Uganda. We call upon everyone who is likely to participate in this to really consider this, because it is for the good of our brothers, sisters, and everyone out there who consumes the services in the health sector of Uganda, because we provide 80 to 90% of the services, especially to the common person down there.
I'm called Elisha Kapongoro. I'm an anesthetic officer at Titueto Health Center 4, that is Changwanzi district. I've been serving as an anesthetic officer for the last 8 years. The problem with the anesthesia, before I go to the problem, anesthesia deals with taking away pain and maintaining the vital function of the patient when he's under surgery. And even under surgery, then post-operatively, until patient is discharged from the patient, from the hospital. Then also has an element of critical care, caring for very sick people. Also, anesthetic officers are called upon to come in and intervene and manage vital function, the respiration, the heart, and other vital functioning. Now in Uganda, the anesthesia service is basically provided by anesthetic officers. Then the anesthetic officers initially were clinical officers who had a diploma in clinical medicine and community health. Later on, due to shortage of anesthesia workforce, the midwives, the nurses were called upon to come in and train and join the clinical officers and be registered by the council so that they practice or they back up the anesthesia workforce by practicing anesthesia. Later on, those cadres were not enough. They had to go to the regional referrals and get enrolled nurses and enrolled midwives to train in anesthesia, still to back up the anesthesia services in the country. These people qualified as anesthetic assistants, and they helped in giving anesthesia care in the country. Later on, as the country grows and the population increases, there has come a degree in anesthesia whose graduates are also expected to enforce or to increase on the anesthesia team across the country. Also, there are specialized doctors. After doing a degree in medicine and surgery, they go for a 3-year specialization in anesthesia and they come out as anesthesiologists. Then they later on either choose to remain anesthesia service providers or go in critical care to do the intensive care services. At least 2 years before you are allowed to go and train as an anesthetic officer. When you come out with your 5-year experience, you are 3 years of, say, clinical medicine, you are 3 years of, say, nursing or midwifery, in addition to 2 years of training, those are 5 years of medical training, plus your 2 years of experience, those are nearly 7 years, but you are again paid as if you are just a diploma holder. Surprisingly, we have been designated to assistant anesthetic officers. Assistant anesthetic officer, and we are being stuck at U5. Not even moving to U4, U3, U2 like any other diploma holders. Now, we don't know where the policies are coming from to call us assistant anesthetic officer, yet we possess 2 diplomas and giving us the same scale as if we have 1 qualification. This has demoralized many officers, and some of them are even thinking of going to raise goats, plant coffee, or do any other thing. They are running away from the profession. So we are calling upon the government and the technocrats in the public service and ministry and the council to come in and rectify the issues of anesthesia providers in the country so that things can move smoothly. Because every successful surgery, behind every successful surgery, there must be an anesthetist. There must be safe anesthesia for every successful surgery to go on. But we wonder why the anesthesia cadre is left behind, is never talked about. The anesthesia service provider, the unsung hero, the anesthesia provider is left behind totally. Because when we are even in theater, in operating rooms, when a patient gets an arrest, gets a cardiac arrest, the whole team lays down tools and they look at an anesthetist as a savior of the patient. It is the anesthetist to command the whole surgical team to resuscitate the patient back to life and to okay the operation to move on. Such a cadre, we wonder why such an important cadre is not recognized at all.
So currently, the history of medical clinical officers, which is actually the biggest professionals I have in the council, registered about 13,000. But out there those ones were not registered. The origin of this was a certificate, diploma majorly, and of recent we have had introduction of a bachelor's degree. So originally when you had a diploma, your promotional levels wouldn't allow you to get into higher levels of positioning in leadership, but you would rise along the public service structure and reach a level of a principal medical clinical officer, but as a practitioner, but not as a manager of an institution, but you are there as a clinical officer, senior in the provision of services. Now we have introduced the desire to have the clinical officers, other cadres, get trained with skills of leadership and management. Now this brings the new arguments. Why can't I then be a commissioner? Why can't I then be a director in the setup? These are areas that are under discussion. And there is actually no law stopping them from being that. But the practice originally, because of the earlier qualifications, restricted that kind of movement. But where we are now, you've heard, there are already people with PhDs in allied health. Personally, I'm a full professor, but I'm a allied health professional. So we are now in the market and competing with everybody. So the challenge is not as it used to be. Now that we have had the qualifications, we are all up to the task now.